Please.
Yes. A very warm good morning to one and all present here today to celebrate World Pre-eclampsia Day 2022 in association with IRIA Samrakshan and IRIA Preventive Radiology. Today, I am really honored to invite Dr. Rijo Matthew, IRIA Kerala, to give the inaugural address.
Soumya, thank you, Soumya, but I'm not going to give the inaugural address. We've got a chief guest here. It's welcoming everyone is my job. So once again, welcome each one of you who have joined for this special session starting today on behalf of on World Pre-eclampsia Day. And we will be having a series of webinars starting today for the next till May 28th. As most of you are aware that India has a high maternal mortality rate and a high perinatal rate, which India contributes to nearly 25% of all the perinatal if you look at all the perinatal statistics, all the maternal statistics, India contributes to nearly 25% of them. So Samrakshan, a project that was initiated by Indian Radiological and Imaging Association to reduce the perinatal mortality and to apply the principles of preventive radiology and the radiologist's role using technology to accelerate this process has been in progress for the last 3 to 4 years and has made considerable progress and interest all over the country amongst all the major stakeholders in pregnancy and childcare and in childbirth in India. So on behalf of the IRIA Samrakshan Committee and the IRIA Preventive Radiology Committee and the IRIA's Kerala State Chapter, I welcome each one of you who have joined here for this World Pre-eclampsia Day webinar, which will have two very interesting talks on by Dr. Bimal Saini and Dr. Praveen Nirmalan on the various aspects of preeclampsia and fetal growth restriction. To inaugurate this session, we are extremely honored and privileged to have the president of the Asia-Oceanian Society of Radiology, the chair of the RSA, and she has been doing a pioneering work in the field of radiology in the Asia-Oceanian region. I have the pleasure to introduce and welcome our chief guest today, Dr. Evelyn Ho Laming. She is a consultant clinical radiologist at Park City Medical Center, Kuala Lumpur, Malaysia. And she is the president of the Asian Oceanian Society of Radiology, serving on the AOSR Council from 2008 and chair of the Radiological Society of North America's Regional Committee for Asia and Oceania. She is the fellow of the Academy of Medicine of Malaysia, honorary fellow of the Academy of Medicine of Singapore, and as an honorary membership of the Chinese Society of Radiology. Evelyn's healthcare and community contributions have spanned over 20 years with innumerable public health talks and webinars on various topics related to her breast health campaigns for nearly 10 years. She authored a booklet on the art of being breast aware. In 2005, Evelyn received the Novartis Malaysian Breast Cancer Council Leadership Award in Breast Cancer Advocacy. Apart from this, my personal interactions with her as part of the QSS committee, she has been taken a lead role in promoting MR safety in our Asia-Oceanian region. Her past leadership roles in the College of Radiology Academy of Medicine of Malaysia as the council member, as its secretary, and the AMM council member, the bursar of the AMM, and she pioneered and hemmed the Malaysian College of Radiology AMM website from its inception in 2001 till 2014 and ran the College of Radiology of Malaysia subsidized value-added mammogram programs. She sat on the Malaysian National Credentialing Committee from 2009 to 2010 and was secretary-treasurer of the ASEAN Association of Radiology from 2004 to 2006. Her areas of interest in radiology include breast radiology, ultrasound, and general radiology. She's a reviewer for Malaysian medical journals. Evelyn authored a chapter, Bridging the Radiological Healthcare Divide with Social Entrepreneurship, in the book, Radiological Safety and Quality in Radiology, Paradigms in Leadership and Innovation. So this is Dr. Evelyn Ho Laming, and we are extremely honored and privileged to have you here on this World Pre-eclampsia Day to inaugurate this session and to give us a message. With that introduction, may I welcome and invite Dr. Evelyn Ho Laming, the President of Asian Oceanian Society of Radiology. Over to you.
Hello, thank you very much, Rijo, for that extremely generous introduction. Salam sejahtera, as we would say in Malaysia, and greetings from the AOSR. Today is World Pre-eclampsia Day, an effort to mobilize worldwide awareness over early detection of pre-eclampsia to avoid culmination in eclampsia that could have serious morbidity and even mortality on mother and unborn baby. Pre-eclampsia occurs uniquely in up to 8% of pregnancies worldwide. Family history of pre-eclampsia, autoimmune conditions, history of hypertension, kidney disease or diabetes, as well as obesity could put someone at risk for pre-eclampsia. For the pre-eclampsia survivors, they are at 2 to 10 times the risk for cardiovascular disease, including stroke, and 4 times more likely to have high blood pressure. It is no wonder then that there are pre-eclampsia survivor support groups out there. In the past, pre-eclampsia has been more a clinical diagnosis. Pregnancies presenting after 20 weeks with high blood pressure, proteinuria, edema, headaches, blurred vision. So how does radiology come in? I heartily congratulate IRIA through Samrakshan and Preventive Radiology and today's other associated organizer, Journal Med and MedPiper Technologies, for establishing the World Pre-eclampsia Week series of webinars from today until the 28th of May. In most hospitals or centers in the world, fetal sonography has become the realm of the obstetrician and the gynecologist. This is where I'm delighted to see in India, there is fetal radiology, championed by radiologists. I am particularly proud to have as colleague and friend, Dr. Rijo Matthew, who is deeply involved in fetal radiology to bring about a change in maternal and fetal mortality. To all of you involved in fetal radiology and the multidisciplinary team, kudos to all of you. Samrakshan being the national program of the IRIA to address the high rates of perinatal mortality, low birth weight, and preterm babies in India is a stellar example of how radiology can bring about a change in maternal and fetal mortality to all those involved in bringing radiology out from the dark room. So this is how India is a stellar example of doing this. Leading the way nationwide on how to use ultrasound and Doppler studies and other biomarkers in imaging combined with clinical features and biochemistry will ensure radiology contributes to national and worldwide healthcare in a meaningful way. Congratulations is also due for the paper that was published, Reducing Perinatal Mortality in India, 2-year result of the IRIA Fetal Radiology Samrakshan program. I hear that this publication, presenting the results of early identification and risk stratification of pregnant women at high risk for developing pre-eclampsia and fetal growth retardation, has garnered international attention. This impactful initiative from India, with evidence accrued and peer-reviewed, could eventually be extended to other countries, especially low-resource countries. We look forward to building alliances for the same cause, a safe motherhood effort. Our solutions, of course, will have to be resource stratified and practicable. Just before I sign off on this message, permit me to mention one of the other initiatives of the AOSR. The first one was the MR Safety Initiative that Dr. Rijo mentioned. It is ongoing, and IRIA also participated with your own Indian awareness program in October 2021. In addition, the AOSR is committed to value-based radiology, as this will ensure we move with the times and continue to be an integral part of the medical world, if not an indispensable part of the multidisciplinary team. Therefore, if you receive a link for the AOSR value-based radiology survey, please participate in this. Every center is encouraged to participate, and this is a survey to bring awareness, as well as to give the AOSR some idea where we are, what we need to do to enable all in our community to be valuable members of the healthcare team. I hope the IRIA, as an integral member society of AOSR, will help to promote this survey through the whole of India and to its neighbors through personal and official networks. Today, it's proof that India practices value-based radiology in the arena of maternal and child health, bringing the relatively invisible dimension of radiology amongst the major stakeholders into the forefront. Congratulations to the organizers for leading the way in pregnancy care and fetal radiology. You have indeed proven that radiologists can indeed guide pregnancy care for better outcomes. Thank you very much for inviting me to inaugurate this kickoff session, the first in a week of webinars.
Thank you, Dr. Evelyn Ho, for the inaugural address and the message on the World Pre-eclampsia Day. Thank you once again. We are honored and privileged to have you here. So we will now move on to the academic session. Let me introduce the National Coordinator of IRIA Samrakshan Project 2022, Dr. Shilpa Satarkar, to take over the academic session. We have got two talks, very interesting talks by two eminent speakers and the various aspects of preeclampsia, fetal growth restriction, Samrakshan, and the research in our country. So they will be talking to us and enlightening us on the various aspects which will give us rare insights into the future and also will help us guide our action plans better to reduce preeclampsia in our country. Dr. Shilpa Satarkar, please.
Thank you, Dr. Rijo, sir. Welcome all to this full week celebration of the pre-eclampsia month. So today is the World Pre-eclampsia Day, and from today onwards, we are starting 1 week webinar series on pre-eclampsia and various complications and things related to pre-eclampsia. So on first of this talk will be taken by Dr. Bimal Sahani. Bimal Sahani, sir, he is from Aurangabad, my teacher from Government Medical College. Right now, sir is director of the Sonoscan Center at Aurangabad. He is a national president of the Society of Fetal Medicine, who works on the same aim of having a maternal and a fetal care. He's also academic coordinator of the Scholar MD Fetal Medicine Training Program for Radiologists. It's a premier institute with all radiology teachers teaching radiologists to get at par with the fetus, and I'm proud to say that I'm also alumni of the same training program. And sir is from Government Medical College Aurangabad. Apart from his like academics thing, as a person also, he's absolutely wonderful. You can say a guide, a teacher, and friend. Every aspect of sir is absolutely wonderful to have with. Considering his publications and presentations, he has authored the second trimester guidelines of the Society of Fetal Medicine, and then he's also co-author for the SFM India oriented guideline statement of the COVID-19 pandemics. He has also various presentations in national and international conferences, and his area of interest is fetal growth and the fetal echocardiography. So today, sir will tell us about how preeclampsia is going to affect the fetus and the early FGR, how these are coordinated, how we are going to identify these things. Over to you, Bimal, sir.
Thank you very much, Shilpa, for those kind words of introduction, and I think a very, very motivating talk by Dr. Evelyn right in the beginning has set the tone for this week. And I think, so well begun is half done. And so I really wish this whole week, at the end is very, very fruitful, where people log in, people learn something new, and most important thing, they put it into practice from the very next day. Now, when they say pre-eclampsia and FGR, very honestly speaking, I was thinking of having two different presentations on that, and trying to merge both of them. Now, women with FGR, 15% of them develop pre-eclampsia. Now, you can have pre-eclampsia with FGR, you can have pre-eclampsia without FGR also, but pre-eclampsia with FGR is a serious condition. It has higher morbidity for the mother. All these HELP syndromes, cesarean section, there is a higher rate. And as far as neonatal outcomes are also concerned, if you take FGR without pre-eclampsia and FGR with pre-eclampsia, the neonatal outcomes are worse when it comes to FGR with pre-eclampsia. See, if you look at the pathophysiology, eventually everything comes off to be nearly the same. Everything is happening at the placental level. So there is a definite interlink between the two. Now, I'm not going to get into the definition and the management of pre-eclampsia, because that is something which is the domain of the obstetricians. Now, Dr. Evelyn said that, yes, she's very happy that, radiologists are taking part in even, screening for pre-eclampsia all over the world. Yes, now it has gone to the obstetricians. But I think the magnitude of the problem is so strong in our country that, it doesn't matter who's doing it. As long as, see, the final aim of all of us being doctors is to give every mother a safe motherhood and every fetus an optimal outcome. And for that, it doesn't matter whether, the obstetricians are doing it. If they are not doing it, we will do it. See, the patient, radiologists are a part and parcel of the management team for pregnancy. See, we have ourselves put us as just imaging people, that we are not technicians. I'm not just going to do the uterine artery Doppler and say the PI is more and leave it on somebody else to interpret what to do about it. No, that a sonographer can also do. But I am a qualified doctor. I need to take a call. I need to interpret the reports. Yes, the patient is with me. It doesn't take much time. Yes, with a little extra time, I can go ahead, take the history of the patient. I can, if the map has not been done before, or I will do that. And the softwares have made life so easy. I put everything on a software and I'm going to get what is the risk of pre-eclampsia. See, there are 10 million women around the world develop pre-eclampsia. If you look at these figures, that is the time when we really start thinking. 76,000 pregnant women die each year from pre-eclampsia and other hypertension disorders globally. So, indirectly what I'm trying to say is that every 7 minutes, one woman loses her life. So if by the time I finish this lecture, there would be another 6 to 7 women who would have died because of pregnancy related, hypertension related disorders. On the other side, because of this, the impact of hypertension on the fetus, there are 5 lakh babies die from pre-eclampsia and other hypertension disorders annually. So 2.5 million preterm births. And now when I say preterm birth, okay, it's not just about giving a live baby to the parents. It is also what is their short-term and their long-term outcomes. That also we need to take care of. Now, if you look at the characteristics, if you look at, yes, what are the risk factors? Now, we see, I'm quickly going to take you through maternal age because I'm talking about India. Maternal age, yes, maternal age of pregnancy is increasing day by day. Indian women are more into their career prospects now. So there was a time, but by the time the woman was 23, 24, her family was complete. But now women are getting married at around 28, 29 years of age, and then they're coming for their first pregnancy at around 31, 32, and maybe for the second pregnancy at about 35 years of age. Parity, yes, that is an important factor. Previous history of pre-eclampsia, inter-pregnancy intervals definitely are increasing. ART pregnancies, we all know that the incidence of prevalence of infertility is very high, and we are using ART left and right. So, every nook and corner you find one IVF center which is cropping up. And so we have a very high incidence of ART pregnancies. Now, family history of pre-eclampsia is important. Obesity in India amongst women is on the rise. And if, South Asian, in fact, this is considered, if you are a South Asian, you are already, you fall into the risk factor category. And then with comorbidities, again, we have a high incidence of diabetes mellitus, we have high incidence of hypertension. So in short, the message that I'm trying to give is that, even all the radiologists and all the obstetricians and even the neonatologists, everyone gets involved into this particular aspect. Even then the people will fall short because, and we produce nearly 30 million babies a year, 30 million pregnancies a year. So, we want everyone, and I think that is the way, and I really, my hats off to Dr. Rijo Matthews and his complete team with Shilpa now taking over that that they have come up with Samrakshan, and I can see the change that Samrakshan has made in the last 1.5 to 2 years. Now, do we need algorithms for screening? Yeah, so for me as a radiologist, I'm going to speak about the screening aspect, and I want every radiologist who's present here today to take this up seriously. So the advantage of screening is it gives me a personalized risk estimate, and you can definitely, if you follow the, there are different protocols, and if you follow the top end protocol, you can actually you can have a detection rate of 97.5 to 99.8% of pregnancies. And this, why all this we want, because we can start aspirin, and the aspirin trial has already shown us that yes, the use of aspirin 150 milligram at night is definitely gone a long way. In about 60 to 80% of the cases, the incidence of preeclampsia has reduced. Early onset preeclampsia has got postponed to late onset, and even has a strong effect on FGR also. So, and then these algorithms help us to evaluate new preventive therapies also. Now, what are the factors that we take into consideration for screening? Maternal characteristics, uterine artery Doppler, mean arterial pressure, and biochemistry, that is the PAPA and the PLGF. I'm not talking about the SFLT yet, because SFLT, is still under, it's still under trials. We really don't have many labs doing it yet. So, that is something we will come forward later on. Now, the maternal characteristics. So what all you need to look for. So it is a simple thing. If you, as a radiologist also, if you just have a height chart and a weighing machine, you can have that. Just you can train somebody to take down the history, the race, the parity. And these are so many things in the first trimester. When a patient is coming to you for an NT scan or a screening for aneuploidy, you are already taking most of these questions. So, you're asking these questions to the family beforehand, and then ask for history of chronic hypertension and diabetes mellitus or SLE, and measurements of the MAP is a very, very important issue here. And I think that is where things are going wrong. The radiologists in their practice do not want to take this up, because on a general, they use a sphygmomanometer for measuring the blood pressure only in cases of emergencies. And that too, I think a lot of centers would probably not have a BP apparatus also, especially the ultrasound ones, because they are not the ones who are really using that. So, it looks very difficult here, because there is a lot of criteria that is given, but nothing. It is just that you have to make the mother comfortable. She should be sitting comfortably, and you should measure the BP at the level of the heart. The legs should be uncrossed. The cuff size should be selected. These are all things which are routine, which we have learned in our MBBS things. So I think the most difficult part is that neither the observer nor the patient should talk for 5 minutes. Now that keeping a woman quiet for 5 minutes becomes a little difficult, and that would probably increase their anxiety. So I do allow them to see a little bit of their WhatsApp, so that they are quite comfortable with that. And then you measure the BP in both arms simultaneously, and the MAP is diastolic blood pressure plus systolic BP minus diastolic BP upon 3. Now, honestly speaking, you don't have to do all these calculations also if you're using the softwares there. And then uterine artery Doppler is something which we are doing as a routine in the first trimester. So there's nothing new about it. Yes, you take that and you take a mean. Now we used to use 95th centile, but there is current evidence which comes that in the first trimester we need to use the 90th centile as the cutoff to calling it as an increased mean uterine artery PI. And with a false positive rate of 8%, the detection rate for early onset preeclampsia with uterine artery is about 48%, not that great as such. And then the biochemical markers, not going into the details of that, but there are two biochemical markers that we take use of, the PLGF and the PAPA. Now, PLGF by itself also has a decent detection rate, but PAPA isolated does not give you a very high detection rate as such. So what would be the ideal protocol for first trimester screening? Yes, you have published algorithms. There are so many algorithms. You have the NICE, the ALCOG, and the FMF ones. And I think the FMF ones is easy to accept because of the availability of a free software, and hence we need to take it. And then you convert the values of the MAP, the PLGF, the uterine artery PI, the PAPA into MOMS. Again, you are not going to do that. The software will do it for you. And high risk is greater than 1 in 100 based on the first trimester combined test. It is recommended that for Indians, we can use the cutoff of 1 in 150 because our incidence is very high. And this risk calculator is available free of charge. So now if you look at this particular chart, you will find that if you use maternal factors alone, the detection rate with a false positive rate of 10%, the detection rate for pre-eclampsia before 34 weeks is 58%. Now, overall, the detection rate for pre-eclampsia as well as FGR for early onset is always higher than for late onset ones. Then, but if you use the maternal factors plus MAP, then this detection rate will go to 65%. I'm specifically talking about less than 34 weeks because that is the place where the decision making and everything becomes difficult because you are the prematurity also becomes an issue. And then if you add this with uterine artery PI, the detection rate goes to 80%. And if you add PLGF along with the MAP and uterine artery, the detection rate goes to about 90%. So where not possible, then you can only use by the maternal factors and the MAP. No problem with that. But you always have to remember that when more the number of markers that you take, the detection rate is going to high. So what is important is, depending upon the institute that you work, the kind of resources that is available, you have to decide what would be the best screening strategy that can be adopted there. So simple approach is go onto the software, go to the FMF Fetal Medicine Foundation, go to the 11 to 14 weeks pre-eclampsia risk. You put in the singleton, the CRL, and put in the history, whatever, whether there is a history of diabetes, diabetes 2, chronic hypertension, the origin, the racial origin is important, and then whether the mother of the patient had pre-eclampsia. So the mean arterial pressure, the uterine artery PI mean, the date of, and then whatever you are not using, suppose you have not done a PLGF, say no, and this would eventually give you that the pre-eclampsia risk from history only is 1 in 105, but pre-eclampsia risk from history plus MAP plus uterine artery PI is 1 in 141. So the risk changes. So your something which is low risk just based on history may become high risk, and you would be able to start aspirin in that patient. And somebody with a high risk may actually turn out to be a low risk by using multiple factors there. And so high risk, we start aspirin. Low risk, yes, again, assessment of risk for preeclampsia at 22 weeks is the way forward to that. And just one few seconds on the serum soluble FMS like tyrosine kinase 1. I always write this down on the slide because it's very difficult for me to remember and say this full name. But you can just say the SFLT. Now the SFLT1 PLGF ratio is something which can be used in the second trimester, and the cutoff is 38 for suspicion of preeclampsia and 85 for diagnosis of preeclampsia. But okay, as of today, let us not get into that. Let us just think about the first trimester screening with the maternal factors and the MAP, and add on with that uterine artery PI, and if the patient can afford, then add on the PLGF. So the whole essence of screening is that you can start aspirin. And the ASPIR trial has shown that if you give 150 milligram of aspirin, it should be given at night, and it should be started as early as possible before 16 weeks. It definitely reduces the maternal and fetal morbidity. And even if you start, even if you eventually diagnose after 16 weeks, you can still start that. Maybe not to that extent, but it may still help the patient, maybe postpone the development of preeclampsia later. So maternal history and blood pressure remain the cornerstone of screening. So the cheapest thing gives you the most important information, increasing evidence to improve prediction with biochemical markers. Addition of PLGF and uterine artery Doppler in the first trimester improves the detection rate, and SLFT PLGF ratio, I don't want, there is still not enough evidence for that. So I end off with the first part of my talk by, with this slide, an aspirin a day. It can make wonders. And for starting this, you need to do a little bit of extra work when you're doing your first trimester scan. And if you can do that and come up with a detection rate, I got some wonderful, I was listening to Dr. Shilpa Satarkar yesterday in one of her talks, and she came up with a wonderful, she gave a wonderful statistics there that there are 24 lakh women who are at risk for preeclampsia in India every year. And if you have a detection rate of 80% with the MAP and uterine artery and maternal factors, then you would be able to detect about 20 lakh women. And if you start aspirin to that, and if aspirin is effective in about 60 to 80%, then you are going to help about 12 to 16 lakh Indian pregnant women from, and at the same time, an equal number of fetuses. So friends, you don't think that you're an imaging person. Yes, you are an imaging person, but imaging is the cornerstone of fetal medicine, and hence all radiologists, if you just extend your a little bit towards the clinical side, you would probably be the best fetal medicine specialist in the world. Then, is this equally effective for screening for FGR? No. The prediction is not as good for FGR as it is for preeclampsia. You will have detection rate of about 12 to 47%. Now, of course, this study, these older studies, they have taken even SGAs, everything was included as FGR. But if you go by the correct definition of FGR and you use the angiogenetic markers, you will find that the detection rate can go to about 67%. But it is more for early onset FGR as compared to the late onset FGR. Now, FGR, do we need to address this issue? See, there is no meaning in this question. Yes, we need to address this issue. We know that there is an increased perinatal mortality and morbidity. We know these babies have long-term age. We know there is no management. The only management that is available is getting this baby out at the right time, neither too premature nor too hypoxic, and definitely not acidotic. So that is the aim that we have. So now you look at this particular chart, you will find in India, the prevalence of T21 is on the left side of my left side, and the incidence of severe FGR is on my right side. Now look, if you look at these, you will find, and the amount of time and energy and money we are putting in screening for the Down syndrome, and how much time do we really put for really screening for the FGR, and even preeclampsia also. Early preeclampsia, the incidence is much higher. So somewhere down the, everything is important, but somewhere down the line, I think we need to divert our energies based on what is more prevalent in our country. Now there are two things, SGA and FGR. The definition of SGA is very, very clear because it is just a statistical deviation from normal. It says that any fetus with an estimated fetal weight less than 10 centile is SGA. But is every small fetus FGR? The answer is no. Every small fetus less than 10 centile is not FGR. 70% of them are actually normal small fetuses. Not 75, it is 70% of them are normal small fetuses, though they are constitutionally small. The 30% of them actually are FGR. Out of that, 10% are because of the fetal factors, because of chromosomal abnormalities, infections, and 20% are because of the uteroplacental insufficiency. So the definition of FGR means a fetus with an estimated fetal weight less than 10 centile on ultrasound, that because of a pathologic process has not attain its biologically determined growth potential. So it's not just estimated fetal weight less than 10 centile, but estimated fetal weight which is less than 10 centile, which because of a pathologic process has not attained its biologically determined growth potential. Now, how do we determine the growth potential? Because that is a concept which is difficult to gauge. Hence, what we are actually doing is we are using the fetal size as a proxy. So that is not the, that is not the ideal situation, but it is very difficult for me to gauge what is the genetic potential of every fetus. So what we are actually doing is we are using the size as a proxy. We know it has its limitations, but at the moment, that is the best thing that we have. Now, SGA versus FGR. So we just saw that all SGA fetuses, are they FGR? We said no. But are all FGR fetuses SGA? The answer is also no. All yes, in late onset, you may not necessarily have a fetus which is SGA or with a fetal weight less than 10 centile, but that could still have fetal growth restriction, but that is not my topic today. So that is a concept which is different, but for today's topic, because I'm speaking on early onset FGR, let me tell you that all early onset FGR fetuses are SGA. So that is an advantage as far as diagnosis is concerned. So estimated fetal weight less than 10 centile, if you have a uterine artery Doppler which is abnormal, or a CPR less than 5th centile, or an umbilical artery PI which is greater than 95th centile, then you call it as FGR, and or the Doppler is the normal, but the fetal weight is less than the 3rd centile, that also will fall into FGR. But if you have fetal weight which is between the 3rd and the 10th centile, and if you have normal Dopplers, then we call it as SGA. But do we leave it at that? No. I will not just say, okay, this is SGA and forget about it, but I will still keep them under surveillance, because an SGA may also eventually become an FGR later on, may start showing Doppler. But the frequency, the surveillance frequency would be different. So now for early onset and late onset, now we have a decent consensus on that, let us use 32 weeks as a cutoff. Diagnosis done before 32 weeks, we call it as early onset. Diagnosis done after 32 weeks, we call it as late onset FGR. So we can say that the inability of the fetus to reach its growth potential diagnosed before 32 weeks of gestation is early onset FGR. Now, the ESOG practice guidelines have come up with the criteria for defining early onset FGR, and the solitary criteria are if you have an AC or an estimated fetal weight less than the 3rd centile, you can call it as FGR, or you have an umbilical artery which is showing an absent end diastolic flow, then also you can call it straight away as FGR. But for contributory factors, you have an AC or estimated fetal weight less than 10 centile, but along with that, either you have a uterine artery PI which is abnormal or an umbilical artery PI which is abnormal, you will call it as FGR, early onset FGR. So, practically speaking, the same things, but they've got it more into a specific consensus, which actually has come from the Delphi consensus there. But early onset FGR not necessarily is always placental maternal cause. Dr. Shilpa, please let me know when my time is getting over, because I can just go on speaking on FGR but so please just give me a 10 minutes warning and I'll, speed up the things.
Yes, sir.
Yeah, and placental maternal cause, that is what we have been talking about, and that is where we use Doppler. But early onset FGR, you have to think of other things also. Think of genetic cause. There could be chromosomal microdeletions, duplications, structural anomalies can also lead to FGR, or congenital infections, cytomegalo, Zika virus, exposure to some drugs, toxins, alcohol, all these things can also lead to an early onset FGR. And so that also needs to be taken into consideration. And now just let us try to understand the hemodynamics of early onset FGR. What is actually taking place? See, once you understand this particular thing, that means you have understood the cascade of events that we get. And if you understand that, the decision making on when to deliver becomes very, very easy. Now, in early onset FGR, the placental disease is severe. So you have more than 30% placenta which is damaged. So the placental disease is severe, and in majority of the cases, not always, but in majority of the cases, you will find that the uterine artery PI is more than the 95th centile. And then now, because of the placental disease, the perfusion is going to be less, and that will eventually get reflected in the umbilical artery, and hence the umbilical artery PI will increase. And usually the CPR being more sensitive, the CPR becomes abnormal a little before the umbilical artery PI also crosses the 95th centile. So you have an umbilical artery PI which becomes more than 95th centile, and then because there is a high resistance flow, there is less amount of nutrition which is going, you have the brain sparing thing taking place, so there is more amount of flow which is going towards the brain, and you have an MCA PI which is less than the 5th centile. Now, as the peripheral vascular resistance keeps increasing, you may have a stage where you have an absent end diastolic flow in an umbilical artery, and you may also have a stage where you have a reversal of end diastolic flow. But before that, let us think of something else. Now, what is happening here is these fetuses are small fetuses. You have 26 weeks, 27 weeks. These fetuses can tolerate hypoxia for a very long period of time. They can tolerate hypoxia for a long period of time. And in early onset, generally it is the nutrition which primarily gets more affected, and hence you have an SGA. You will always have an SGA there. Now, because these fetuses can tolerate hypoxia for a long period of time, the heart gets more time to function. The heart has to pump more blood against the high resistance. And so there is enough time for the heart to keep pumping more and more blood. But then what happens is, because the heart is working so much, eventually it starts having an effect on the cardiac function, and that eventually gets reflected in the ductus venosus, which you find that the ductus venosus PI which increases. And so this stage is a stage of cardiovascular adaptation that is taking place. And then you have a ductus venosus PI which is more than 95th centile. You get you can have an absent ductus venosus PI. You will have reversal of A wave in the ductus venosus. You can have abnormal, that would lead to an abnormal biophysical profile, the CTG deceleration, and eventually, if still the pregnancy is continued, the fetus is going to die. So, this is a stage where you have a ductus venosus PI which is greater than 95th centile. After that, you start getting into a stage of severe acidosis. And we don't want to go into that stage of severe acidosis. So that is why the ductus venosus is a very, very important vessel as far as early onset FGR is concerned. Now, decision making in early onset FGR and management, yes, you have the fetal blood sampling. We don't do NST, CTG. They have their own limitations. Computerized CTG, excellent thing. We don't have it in India, 1 or 2 places. Biophysical profile, again, has limitations, has important role in late onset FGR. So eventually we are left with color Doppler. So again, that is where the radiologists come in. So we have something in our domain. And so we just don't need to do the Dopplers and give the waveforms and give the PI to the crowd. We need to interpret it ourselves, and we need to give our suggestions on that. Now, the ISWA guidelines actually, tell you that once it is more than 26 weeks, and if you have a biophysical score which is less than 4, and see, they have used the CTG more, if there is a spontaneous persistent FHR deceleration after 26 weeks, you just have to deliver. But between 26 to 28 weeks, 6 days, you have a reversal of DV A wave, STV. So, these are all, because they have used so much of an STV, I will tell you a more simplified method, and that is the stage-based protocols from Barcelona. Actually, they are telling you the same thing in a more simplified way. They're easy to follow protocols, and because you have an app, you can just put in the findings, and that helps you. So we will go through the Barcelona staging. So they have divided the FGR with Doppler changes into 4 stages. The stage 1 is the stage of mild placental disease or severe smallness. So if you have a fetal weight less than 3rd centile or less than 10 centile with any of these factors, then it is stage 1. But now they have removed umbilical artery and MCA from it, and they've just put CPR because the CPR becomes abnormal before these become abnormal. Then stage 2 is the stage of severe placental disease. You have an absent end diastolic flow in umbilical artery or an aortic isthmus reversal. Again, very debatable whether we should use aortic isthmus or not. I can speak from on both the sides for it and against it, but maybe we leave it for some other day. So as of today, let's say that, okay, absent end diastolic flow in umbilical artery is, stage 2, and stage of 3 is stage of early acidosis, where you'll have reversal of end diastolic flow in umbilical artery, or you have a DVPI, which is greater than 95th centile, and stage 4, reversal of A wave in ductus venosus, or abnormal computerized CTG, or you have a biphysical profile which is less than 4. They would all actually suggest that there is severe acidosis there. Now,
sorry to disturb you. As you said, last 10 minutes, I need to inform you. So last 10 minutes.
Yeah. I'll just
thank you,
cover up with this and let you know, finish off. So the risk of, the decision making is based upon, you just have to decide what is more dangerous for the fetus at this moment. Is it to, is the prematurity more dangerous, or the hypoxia is more dangerous? And so, because every day the fetus spends in utero, before 28 weeks, the morbidity reduces by 2%. And between 28 to 32 weeks, every day the fetus spends in utero, the morbidity reduces by 1%. So the whole issue is that I want the fetus to remain in utero as long as possible, but at the same time, I don't want the fetus to go into acidosis. So that is where, a simple story is, just imagine yourself on a building. You are in a building, a high riser, and the building has caught fire. The fire is coming from down. Each floor is the gestational age. The fire is the hypoxia or acidosis, and the safety net is the NICU. Now, whether you will jump or you will not jump will depend upon 2 things. What floor are you on, and how severe is the fire? So again, I'm left with the same thing, whether, what is the gestational age and how severe is the, how severe are the Doppler findings for me. Now, if I am on the 14th floor and I see that the fire is mild, okay, it is up to the 4th or 5th floor, will I jump? No, because if I jump from the 14th floor, my chances of dying anyway are much higher. And so, and I'm checking, I'm not leaving it. I'm seeing that the fire is not, it's still far away. So let me go down. There is no escalator because of fire. So I start climbing down one floor, but every floor I climb down, I check outside the window how far the fire has reached. Now, if I'm on the 12th floor, the fire has reached the 7th floor, I still don't want to jump. My risk is more. So what I do is I still start climbing down. And if I reach the 10th floor and the fire has reached the 9th floor, yes, now this fire is more dangerous. If I don't jump, anyway, I'm going to die. So better thing is I jump. I believe on the safety net, on the fire brigade team there, which is holding the safety net, the NICU. Yes, I may have some problems, but I would still survive. And there is a good chance that, maybe I don't have too much of problems. I could still have, very, very little postnatal problems there. But suppose I'm just on the 3rd floor and there is a mild fire, I don't want to take that chance, because I don't know what is the speed with which the fire is going to come. And that is the reason once I'm on the third floor, then I will jump. That's okay. Maybe a little scratch here and there, but I'm sure I'm not going to have a lot of problems because of that. And so if you're on the 37th floor, you should take a call. So that is on the 37 weeks, 38 weeks, you're closer to the ground, you need to take a call. So stage 1, 37 weeks, you deliver. And if it is not 37 weeks, you monitor it weekly. Stage 2, 34 weeks, deliver. Otherwise, monitor it bi-weekly. Stage 3, 30 weeks, deliver. Otherwise, monitor it 1 to 2 days. Now, even the ISO protocol says that, okay, if it is stage 2, even 32 weeks, you can deliver. Stage 4, 26 weeks, you have to take a call. There is no chance because it's already severe acidosis. Then there is reversal of A wave in ductus venosus. I'm going to take a call and deliver there. And this is the beautiful chart from Barcelona, which we all should have. This gives you all the criteria, all the stages, and even the mode of delivery, and at what gestational age you should deliver and how you should monitor. And if you just use this and in fact guide your obstetricians, you can actually become a part and parcel in the decision-making team there. Now, there is one more important thing. Now, once you see an umbilical artery which is abnormal, if you see it before 26 weeks, then the placental disease is definitely severe, and you are going to get the critical Doppler abnormality usually less than 29 weeks. If you find abnormality in the umbilical artery less than 29 weeks, then by 33 weeks, you get severe Doppler abnormalities. And if you do it before 31 weeks, if you get it by 35 weeks, you get. Now, this is just, this is a rough estimate of things. This helps you in counseling the parents that, yes, probably we can push on, we'll try. And, but yes, this is not really going to go too far, but, we need to do quicker monitoring. So in early onset FGR management, identify a small fetus, do Doppler, distinguish between FGR and constitutionally small fetus, rule out fetal causes, stage the FGR and plan surveillance, and then decide on when to deliver. An objective protocol-based approach to decision-making is now validated, and ductus venosus evaluation is the cornerstone for assessing when to deliver in early onset FGR. That becomes a very important thing. I actually had a few cases, but I'm short of time. I will take you through only one case. Early pregnancy, 8 weeks, dates were corrected. 19 weeks, 5 days, you have this kind of AC, which is less than the first centile. Fetal weight is at the third centile. The question in my mind is, yes, is this FGR? The dates have been corrected. Yes, anyway, by definition, also it's FGR. Do I need more information? Yes. I saw the FTS, uterine evaluation was not done. Presently, no structural anomalies, no soft markers, but the Dopplers are showing an increased mean uterine artery PI and an umbilical artery PI, which is more than the 95th centile. Now the question is, yes, this is stage 1, that is not a problem. Any other investigations? Yes, I would actually want for genetic evaluation and infection, the torch also. Then patient may opt for termination because there is so much of a growth restriction which is occurring there. So we need to give them all these information. Yes, this may end up, but we need to go to at least 26 to 28 weeks. So all this information is to provide it. And when would you like to follow up? Now, if this is 19 to 20 weeks, stage 1, yes, I should do it every week, but how is it going to help me? So after 1 week, if I see that the ductus venosus is abnormal, am I going to deliver it? No. So, we call them after 5 weeks. So, but the patient refused all genetic testing. They were called after 5 weeks at around 24 weeks, but they came at 26 weeks, 5 days. And then, of course, growth side had come down. There was reversal of flow in the umbilical artery. DV was normal, aortic isthmus was normal, 26 weeks, 5 days. So these are the findings that we have, but the ductus venosus is normal. So this is for me stage 3, but it is 26 weeks, 5 days. So we thought we will repeat the scan every 2 days, but the patient came directly after 5 days. that is the time when there was a reversal of diastolic flow in the aortic acistomas. Ductus venosus PI was greater than 95th centile, but there was still forward flow in diastole in ductus venosus, and hence we asked for, that we will repeat a scan the next day, but the patient came after 2 days. And after 2 days, at 27 weeks, 5 days, the reversal of A wave. Now, this is stage 4. This is a stage when we would like to get this baby out. Maybe 2 days before also would have been right, but then yes, the patient also was very, very educated, and they wanted to pull on as much as possible. And then, and this baby, a good 485-gram baby, was born, spent 40 days in an ICU and went home. But in early onset FGR, before 30 weeks, the critical endpoint should be a critical abnormality in the ductus venosus. And this lady had hypertension in the previous pregnancy, had from 27 weeks onwards, and had delivered at 34 weeks. So there is a history there. She was already on aspirin, NT was normal, uterine PI was high, 20-week scan was corresponding. So we asked for an early growth scan at around 27, 28 weeks, but she came at 29 weeks, 5 days. BP was 160/92, stage 1 findings, umbilical artery PI high, estimated fetal weight at the 5th centile. So we suggested follow-up after 1 week. Maternal blood pressure now was 162/94, pedal edema, albuminuria, but still stage 1. So follow-up after 1 week, 31 weeks, 6 days, still stage 1, but now there's maternal ascites, the BP is uncontrolled, 210/140. So, we keep saying, okay, Dopplers are stage 1, Doppler is stage 1, we will follow up. No, you have to take this call, because remember one thing, maternal condition supersedes everything. So that is the priority. Fetus is important, but maternal condition is more important than the fetal condition at that particular moment. Hence, that is where the role of pre-eclampsia comes in. And that is where our protocols as far as delivery decision making has to change. And thank you very much. I will end with this poem by unknown resident in Dublin, right, somewhere in 1800s. It was written that I am a fetus in the womb. I fear it may become my tomb. If only I could give a shout to make my doctor get me out at the right time, neither too premature nor too hypoxic, and definitely not acidotic. And with this, thank you very much. Thank you, Shilpa, for giving me an opportunity to be a part of this noble venture that you all have taken. From my side, any help required anytime, I will always be there, and please feel free to get in touch with me for any help required at any time. Thank you very much. And thank you, Dr. Rijo, also.
Thank you very much, Vimal sir, for your wonderful talk as usual. The impact of preeclampsia, the diagnosis of the implications on growth, the early FGR, absolutely, it was really, really wonderful how to go ahead with the stage-based protocols and everything. You explained it in a very, very lucid style. So thank you very much, sir. And I hope everyone will start following you and will be doing, as you explained that it's very easy to have just a BP apparatus. We can train our staff. As radiologists, we only have to do the uterine artery Doppler. Once we train our staff, it becomes very easy to have the preeclampsia screening. Thank you very much, Vimal sir, for the same. Yeah.
Before we go on to the next session, I think questions we may be taking up at the end of both the sessions. And but before that, Vimal Sani sir, I just want to highlight one particular point. Preeclampsia, especially in the central part of India, we see quite a bit of preeclampsia, early preeclampsia, and a correlation with early FGRs. Had a doubt whether our perception that 75% of SGAs are 75% of small for date baby or small fetal weight less than 10% percentile are constitutional, and only 20% are uteroplacental insufficiency. Where do we get that data from? Is it an Indian data or
no? It's not an Indian data. It's not an Indian data.
Sir, I seriously doubt that data.
Even I doubt.
If you look at if you look at Lalit sir's study in Guna in Madhya Pradesh, we see considerable number of early FGRs, early preeclampsias, and there is a significant correlation there. And numbers of early FGR and FGRs, even in the Samrakshan study that we did for 2 years, this is not constitutional babies are not just the 75%. It is much lesser, and the true FGRs are more actually. So this is one area that we need to explore further.
I think a lot of them at first sight would be an SGA, but you do later on find that they see. We eventually have to use some criteria to whether to call them as FG, because the moment you call them as FGR, your surveillance will have to change. You will have to put them on a very close surveillance. So if you still find that your Dopplers are normal, see, there are so many questions in FGR which are still unanswered. And we need definitely we need our local this thing. There are so many times I find that yes, this appears to be constitutionally small, but we see them after 2 weeks and we find that the CPR has now changed, and that is an SGA has actually become an FGR. So these are all the
Yes.
changes that we do see, and so that's an international statistic, but even in Indian circumstances, there is an issue. One of the major issues is that is about the growth charts that we follow. See, our Indian growth charts that we follow actually undercall SGA. And if you follow headlog, you will overcall SGA in our Indian population. But then it is better to overcall SGA rather than undercall SGA. Because if you overcall SGA, at least you are going to do the Dopplers and you are going to at least pick up that subset which actually requires much closer surveillance there.
Yeah, I think we have to start on the premise that the Western data has got 75% small constitutional this thing and very less 20% FGR, because generally their FGR is less. It is not the case in India. India has got nearly 25 to 30% of FGRs. So that data, when we follow it, that maybe that can, it is one area I think we need a lot of research with our own data and come to conclusions there. So thank you, Bimal Sani sir, for that wonderful lecture. You have taught us new insights, categorically stated some many facts that we have to put in use as far as Samrakshan is concerned. Thank you once again. Shilpa, we can move on to the next session.
Yes. So next, I'll be inviting Praveen Nirmalan sir for his talk. So since last 2 years, 2019, we have started with Samrakshan things, and we are filling the Samrakshan online form. So sir will be dealing with how the Indian scenario is changing with the Samrakshan data, how when we have started preeclampsia screening, when we have started the use of Doppler in the growth restriction, how the Indian scenario is changing, how Samrakshan is helping India to change the scenarios. This is what Dr. Praveen Nirmalan sir will be talking on. So basically, Praveen Nirmalan sir, you can say, is the backbone of Samrakshan. All the things whichever we give on the online thing, all they are like very well analyzed, and always he's like putting questions in our group. So no, what he will do. He's just stimulating our brains in different aspect of the preeclampsia and things regarding our own country. So basically, sir, he's basically trained from Thrissur, Kerala, and has done fellowships in Mumbai, and has done his master's in public health from Johns Hopkins School of Public Health in USA. He is a lead national and international. He leads national and international research since 2 decades in ophthalmology. Basically, sir is ophthalmologist, but we feel that now he's a radiologist. So much he knows everything about imaging and radiology. So he has done this research in ophthalmology, public health, obstetric, gynec, and critical care and radiology. Is a big, as I told you, is a backbone of Samrakshan and Preventive Radiology program. There are over 80 publications in various journals. Sir is also monitoring over 200 MD, DNB, and PhD students, and the clinical data and everything statistics related to that. And also is a lead faculty of courses of quantitative research methods, clinical epidemiology, biostatistics, and writing in research papers. So with this introduction, I invite Praveen sir to have his talk. Welcome, sir.
Thank you. And let me just share my presentation. So let me start by thanking IRIA Kerala, the IRIA Samrakshan Committee and the IRIA Preventive Radiology Committee for giving me this opportunity to present to you the results. I'll be focusing mostly on the results of the Samrakshan program. And this presentation is, I'm doing the speaking, but the presentation is for the team Samrakshan that has done the groundwork, done all the hard yards. And I would like to therefore thank the IRIA Samrakshan Committee who have been doing this, the committee for 2022, who have been doing great work in the field of perinatal mortality in India through this program, and for trusting me with the responsibility to give a fair communication regarding the results. Talk would have two sections. One where I discuss on the genesis or the origin of Samrakshan, and then where I move on to the results of Samrakshan. And before we start, let me request you to have a look at this slide where we are comparing the numbers and the rates between the UK and India in terms of childbirth, in terms of the incidence of pre-eclampsia, in terms of actual numbers of pre-eclampsia. And I want you to look at the slide quite carefully for two reasons. One, very obviously, we have a large number of childbirths. We have a large incidence of pre-eclampsia. We have a large number of women with pre-eclampsia. So we know we have a problem. If you look more carefully, you can see that we probably have more radiologists in India than the number of women with preeclampsia in the UK. In the PE numbers, you can see that we have about 18,000 radiologists in India. The UK has just about 16,000, less than 17,000 women with PE. And it struck us that in spite of having the expertise, in spite of having a huge population of women with preeclampsia, if you look at evidence, either in terms of clinical evidence, in terms of programmatic evidence, in terms of what can be done, there is a big disproportion between the research and the evidence that comes from the UK and has come from India. And that led to a thought that, well, maybe it's time that we need a program that is centered on the Indian women. A program that acknowledges that we have a huge problem in India, that acknowledges that we need evidence from India. And that program has to be compassionate. It has to understand the fact that the pregnant woman in India has got several factors that are running around her. It's not just a reproductive need that is being met. There are social needs, there are family needs, there are identity needs. There's a whole set of different dynamics that are running around the pregnancy with the women in India. And so there has to be an element of compassion in this program. There has to be an element of justice where we understand that we must meet the needs and rights of this woman in India. And it has to be equitable. It has to be something that she can afford. It has to be something that her family can afford. Given the highly patriarchal system that we have in India, even though that's changing, we must acknowledge that it must be something that this particular woman can afford to access and make use of. And something that the family would not mind offering to this woman. We then figured that we need evidence. And it should not be just evidence. There is evidence out there. We need evidence that is locally relevant to the different situations that we have within India. That's relevant to this particular Indian woman. And the evidence must be inclusive. And when I say inclusive, we are looking at two aspects. I would interchange I and we as we talk, but essentially it means we, because it's a team effort. So we're looking at two aspects here. We're looking at aspects that the evidence must be inclusive of all sections of the population of Indian women, pregnant Indian women. And equally important, the evidence must be inclusive of all levels of healthcare practitioners It should not be evidence that's coming only from select tertiary care centers, because then we miss out on what's happening. 90% of what's happening with the pregnant woman is happening at the secondary level, at the smaller nursing homes, at individual practices. And if we don't include them, if we don't include their learnings, then the evidence becomes skewed. And so we wanted inclusiveness in two directions: inclusiveness on the populations that are going to be included, inclusiveness on the healthcare providers as well. Evidence, solutions, plenty of it in the literature. I mean, we are quite happy with it, that there is plenty to work on. We have the aspirate trial. We know that 150 milligram of aspirin, low dose aspirin once a day, started early, works. We have the screening for pre-eclampsia by maternal factors and biomarkers at 11 to 13 weeks gestation. We have the calculators available to estimate the risk for pre-eclampsia and for FGR in the first trimester, second trimester, third trimester. We have guidelines, and we even have the recent statement by the FIGO, the International Federation of Gynecology and Obstetrics, on screening, a pragmatic guide for first trimester screening and prevention that advocates the use of 150 milligram of low dose aspirin. So we have evidence there. We have evidence. We have the means to estimate the risk. So we have something to start building on. And so we said, okay, now let's start scaling up. Then let's look at skill enhancement to bring all radiologists in India up to scale. Let's start a training program. Let's start a series of training programs. And so we developed trimester-specific protocols that integrated fetal Doppler into the routine ultrasound assessments. We held a series of continuous medical education programs that were initially offline. And then when the COVID virus decided to pay a visit, we converted that into online webinars and continued the CMEs. Equally important, we formed learning groups after each CME where we could continue to support, mentor, and learn from each other based on the experiences of doing what we had suggested as part of the protocols. Because essentially every program is as strong, only as strong as the weakest link. And if the weakest link is really weak, the program is going to fall down. And so we wanted to make sure that everyone is well trained, everyone has the opportunity, has the freedom to contact us at any point of time. Us meaning any trainer, any mentor, at any point of time, 24/7, with any doubt that they have relating to either the implementation of the protocol, an actual case, how doing it. And we formed WhatsApp groups, we formed Telegram groups, we had forums where we had lectures and videos played in. We have a library set up where we have documents and videos placed in. We have a playlist, a video playlist of all the Samrakshan related educational videos put up, and that's there on the IRIA website as well. If you look at the programs menu button on the top, and under that you can see Samrakshan, and if you click on that, you can see all of this. So are we now ready to apply solutions? We have evidence, we have scaled up, we have trained, we know that there is a need, we know that we have the frame of the program in mind, that it has to be compassionate, equitable, providing justice to the women. Are we there yet? And we came to the next problem that we have. And it's a problem that I think we must seriously consider. I would request you to look at the two women there and then try to find similarities between them. Granted, they both are young. Show me a woman who is not young. They both are beautiful. Is there a woman who is not beautiful? Both of them are strong, and we know that women are strong. That's what nature tells us. Nature gave the responsibility of propagating our species, the human species, to the woman, because nature knew that man can inflict pain, but man does not have the capacity to bear the pain of childbirth like a woman can. So we know that they're strong, but other than that, are there really similarities between these two women? And so we thought, so then can we just take the solutions that have been developed in a particular population, apply it as it is to our population? Will that work? It can be the best of solutions. It can work, but that's not the point. The point is, do we know that it will work? And so we said, well, that's the best evidence we have now, so let's apply that. But let us also check to see how well is that working. So let's gather evidence of that. So how do we gather evidence? Do we need to gather evidence? That led to a lot of chatter saying, well, the evidence is already there. ASPRE has done this, FMF has done this, Barcelona has done this. People have done this and they're well-conducted studies. No doubt about it. They're well-conducted studies that we should replicate. Do we need to then reinvent the wheel? So I bring you back to the point that we had when we started Samrakshan, that the evidence must be locally relevant, must have local relevance. And if it must have local relevance, it must be generated from our population. It must be inclusive in terms of the diversity of women that are being included in the program. It must be inclusive in terms of the practitioners that are contributing data to the program. And we must evaluate this. So we also said Samrakshan must improve the quality of care that the pregnant woman receives. That's non-negotiable. Must meet a clinical outcome concerns. Non-negotiable. Must generate evidence for questions that matter to her, that matter to this particular pregnant Indian woman. And so we designed the Samrakshan forms, where we said, well, let's then document this systematically. Let's collect information on this and let's make it easier. Let's make it an online Google form, which is privacy protected, anonymized, and let's have an online submission. And the form for us had two primary purposes. One, a learning teaching moment where at each variable, as you're documenting it, you get doubts, you clear your doubts with your mentors. And so there is a learning teaching moment happening with the filling of the forms. And the forms were initially being transcribed on paper after you have seen. So as you're doing it, you're starting to think, well, why is this so? Why is that so? Why is this happening? Talk to your mentor. We have dedicated WhatsApp groups, Telegram groups for that. So talk to your mentor. And then you have a discussion on that. You have an individual discussion, one-on-one. You have a group discussion as well, peer-to-peer learning. The form was also the basis for us to look at, see what's happening, or data analysis based on what is coming from this. So we designed the forms for it. So now we were ready to apply the solutions and see what's happening. And that is the genesis of Samrakshan. And I want to share the genesis of Samrakshan because sometimes when programs move further along the line, we tend to forget why they were formed in the first place. We tend to forget the ethos behind it. We tend to forget the work that went behind the development of the program. And it's important to keep that in mind so that further directions can happen, aligning with those base concepts. So Samrakshan started in July 2019. And what we knew when we started was that 8 to 10% of pregnant women in India develop P. It comes from the National Health Portal of India and from fewer studies that are there in India. We know that about 20 to 35% of fetuses may be growth restricted. And we also know that the data around the incidence of FGR in India varies widely by region, even within regions, and by definitions as well. So the data is a bit, let's say, dicey, but we know that a large chunk of the population, a large proportion of the population actually have FGR, and it's about 20 to 35%. Some studies even quote as high as 45% still. 20 to 35% would be a fair estimate. We know that we can assess risk using clinical details, map, and the mean uterine artery Doppler at 11 to 14 weeks, and we can categorize people into pre-eclampsia or FGR. We know that's possible. Now the question is, will the algorithm call everyone as high risk? And what Samrakshan found, what we found in Samrakshan, and this is where I start talking about the results of Samrakshan, of what we found. This is based on the data that we found, this segment of the talk. Samrakshan found that nearly 1 in 5 women in the first trimester may need low dose aspirin, 150 milligram, once daily at bedtime, and based on a 1 in 150 cutoff. So 1 in 5. And when we looked at the what happens if we use a cutoff of 1 in 100, what happens if we use a cutoff of 1 in 50 to these numbers when we say 1 in 5. If we use a cutoff of 1 in 50, it's less than 1 in 10 that's being picked up. So you can see that the numbers change and change drastically. And that that is probably more in tune with what we know as the prevalence of PE in India, 8 to 10%. But it sort of 1 in 15 sort of means that you're looking only at the more severe cases. So the question is, why did you choose 1 in 150 then? And the reason is that Asian Indians have a higher background risk for PE and FGR. And so we want a higher cutoff that is capable or allows us to also get the milder cases, milder risk levels of women into the screening, into the program, into the surveillance. And so we chose 1 in 150. The FMF also says that for African and Asian women, 1 in 150 is appropriate. And it was important for us, as more important, equally important for us was the fact that many women do not return for follow-up assessments. First trimester assessment in India uptake is around 70%. For ANC assessments, it's less than 60%. Even in the recent National Family Health Survey 5, ultrasound assessments are about 60 to 70%. So we know that one-time visit, we may not get another opportunity to get hold or manage that woman. So we need to get them. When we get them, we need to maximize our ability to provide the best care to them. So I said 1 in 150. And if we find that the woman is at higher risk, then we start them on low dose aspirin, 150 milligram once daily at bedtime. And we continue till 36 weeks or till childbirth or till the development of preterm PE, whichever is early. Now, in the second trimester, we have the routine ultrasound assessments, we have the TIFA, and then we integrate fetal Doppler. I'm not going to go into the details of the second trimester assessments here. In the third trimester, our primary focus was on, besides the estimation of risk of preterm and term PE, was on the use of fetal Dopplers and staging of FGR, and we use the Barcelona protocols. And we have already heard about the Barcelona protocols and how they can be applied. I'm not going to talk more about that here. And we looked at the program forms and we analyzed the program forms, and we found that most of the data was coming from individual practitioners residing in mostly rural tier 2 cities, tier 2 towns of India. So we had data from academic teaching centers, we had data from tertiary care centers, and we had a lot of data from individual practitioners, diagnostic centers, group practices spread out all over India. 16 states in India, nearly 40 districts. So we have, and we have a mix of urban, we have a mix of rural data. So we have, I wouldn't call it entirely exactly representative data for India, but we have a fairly representative data for India. And more importantly, we have evidence from the program. So this program was not designed as a multi-center research study with strict rules. The program is a program, but we are building in evidence from within that program. So in terms of screened numbers, first trimester, second trimester, third trimester, nearly 5,000 women in each trimester have been screened. And we have childbirth outcomes for nearly 3,000. So nearly 3,000 childbirth outcomes. What's the impact on PE? We found that the incidence of PE reduced from 9.85% at baseline when we started Samrakshan. When I say baseline, we took the first year of the program as the baseline. We didn't want to rely only on the 8 to 10% that was previously known. We looked at the first year data as a baseline, and it reduced from 9.85% to 2.76%. And if we extrapolate that incidence, PE reduced from 24 lakhs to 8.28 lakhs through the program. And that's a significant reduction. You could see that it matches with what is already known in terms of applying the ASPRE results, that it would reduce by about 16 lakhs. We are seeing that here. We are seeing that in real time. We are seeing that as evidence from within our program, that it has reduced from 24 lakhs to 8.28 lakhs. We found that preterm PE developed in only 20.51% of high-risk women. So low-dose aspirin actually benefited 80% of high-risk women, which is again what ASPRE says. The ASPRE trial puts in that it will benefit about 75 to 80% of women or 82% of women. And we're seeing that. We are seeing that within the program. And among the women called as low risk by the algorithm in the first trimester screen, only 1.94% developed P. So we are seeing that the algorithm is helping. We are seeing that the use of low dose aspirin is helping, and we are gathering evidence that from our population, from our program, that this is actually happening. How about the impact on FGR? We found that the incidence of FGR reduced from 33.71% to 11.71%. And if we extrapolate that, we are seeing that FGR reduces from 10 millions to 3 million. Huge reduction. Mean birth weight, we found that the mean birth weight improved from 2.64 kilograms to 2.75 kilograms, which if you look at it, seems that, well, it's not too much in terms of the decimal points, but it was still a significant, statistically significant improvement in the mean birth weight that we are seeing. Preterm births. Preterm births reduced from 29.54% at baseline to 19.28%. And if we extrapolate that, we are looking at preterm births reducing from 69 lakhs to 32 lakhs. A huge reduction, a huge reduction. Small babies, a proportion of babies that were called as SGI were now increased from 4.92% at baseline to 8.25%. And this was because of the reclassification based on Doppler from FGR to SGA. We have seen the definition of SGA, in the previous presentation. EFW, estimated fetal weight, 3rd to 10th percentile, and a normal Doppler. And the reclassification actually shifted the number of babies that were now being called as SGA. Earlier it was 4.92. Now it's 8.25%. And does that matter? We can see that, and when we extrapolate those percentages, nearly 22 lakh fetuses are now reclassified from FGR to SGA. From FGR to SGA. And again, does that matter clinically? It does matter clinically. Stage 1 FGR, what we found through the Samrakshan program was that, and through the surveillance and through the communication with the obstetricians was, and other stakeholders, was that stage 1 FGR babies carried to term improved from 56.94% to 75.32%. So earlier 1 in 2 babies was preterm. Stage 1 FGR babies was preterm. Now it's just about a quarter that's preterm. 75% is being carried to term and is being delivered at term. We looked at abnormal Doppler in the 3rd trimester, and we found that fetal Doppler tests, anyone, either the uterine artery, the umbilical artery, the MCA, or the CPR, was found to be abnormal in 1 in 5 pregnant in the 3rd trimester. Does that have clinical implications? What we found was that the 3rd trimester abnormal fetal Doppler tests were significantly associated with late stillbirths, an odds ratio of 37.2. And yes, the 95% CA shows a wide range, but that's because the number of stillbirths is on the lower side. And so the 95% CA will naturally be wide. It's not a narrow range. But we found that 3rd trimester abnormal fetal Doppler tests were significantly associated with late stillbirths. We didn't find that association, a significant association, even though the odds ratio were higher with term stillbirths or with neonatal mortality. But we found it with late stillbirths. We also checked to see if the ability of the individual components to discriminate for late stillbirths, term and neonatal mortality. And we found that the AU-ROC, using the ROC curves, area under the ROC receiver operator characteristic curve, of all the Doppler measures was excellent for late SV. So it can discriminate between those who are at higher risk and not at higher risk for late stillbirths. All AU-ROCs were more than 0.85 and AU-ROC closer to 1 is excellent. And this is in the range of excellent. Equally important, what we found with the analysis of our data, it's something that we must discuss and probably we'll be discussing through the series of webinars that are being planned after this, through this week, was that in fetuses with a weight, estimated fetal weight more than the 10th percentile, we still found abnormal fetal Doppler tests. And that's a group that we usually tend to say do not need to be monitored. You don't need to possibly do a fetal Doppler unless you really feel that something is going off. We found that abnormal uterine artery PA was there in 9.20% and abnormal MCA in 7.25%, CPR in 8.92%. And the abnormal umbilical artery PA was there in 3.90%. So we are seeing that the possibility of an abnormal fetal Doppler test exists even in fetuses that have an EFW, estimated fetal weight, more than the 10th percentile, what would routinely or conventionally term as an AG. What did we find in terms, and when I said earlier about the implications of the classification on SGA and carrying SGA to term, what we found in perinatal mortality was that we didn't have perinatal mortality in the SGA group in Samrakshan. In the no SGA group, we had 1.48% perinatal mortality. Of that 1.48%, nearly 40% had an abnormal Doppler test. And the remaining did not have. Now, an abnormal Doppler test is one marker, but you can have a sudden deceleration of fetal well-being even before the Doppler picks it up and other measures picks it up, as especially in term, and especially if the baby is an AGAB. We found that perinatal mortality in FGR was 3.70%. So there is a difference. There's a difference there in the perinatal mortality in the three groups. In terms of neonatal mortality, we found that the neonatal mortality in Samrakshan was 9.86 per 1,000 live births. And the purple figure is our comparator from the National Family Health Survey for 2016, 29.5. So it reduced. If you look at that 29.5, 9.86. And the comparator in green is what the Sustainable Developmental Goal targets for 2030 are. We want it to be less than 10, we have reached that. Perinatal mortality rate has reduced from 36 to 18.97 per 1,000 childbirths. Maternal mortality has reduced to 58 from 113. A big reduction. Sustainable Developmental Goal targets for 2030 is 70. We have reached that. And we have reached that just by adding a few components to the whole process, by adding the algorithm-based risk stratification, checking for MAP, adding uterine artery Doppler to the mix, and recommending low-dose aspirin. And you have achieved all this. And through the process of the program, you are also interacting with other stakeholders in the care of the woman, especially the obstetrician, the neonatologist. You're also talking to the family members. You're also counseling them to make sure that they go for regular follow-ups, if not with you, at least with someone, that they go for regular follow-ups. You're trying to build a greater ANC coverage, sustainable ANC coverage through the program. And all of this is working. And this is a proof that it is the evidence that's coming from the Samrakshan program based on the data that the practitioners of Samrakshan, radiologists in India, have submitted. Now let's just do the math. Low dose aspirin 150 milligram once daily may cost you 1 Indian rupee per day. At least when I bought it, it was 1 rupee per day for 150 milligram. Low dose aspirin daily for 25 weeks, 36 weeks, 11 weeks. 25 weeks will cost around 175 rupees. PE, the management of pre-eclampsia, will cost an additional 30,000 to 150,000, 150,000 rupees for treatment. So it's a no-brainer to see what helps. The math is staring right there. The evidence from the program is right there. Now, that is the results from the Samrakshan. Let me just move on to the challenges and opportunities that we see. We found that the second trimester assessment prevalence of congenital abnormalities 3.81% is significantly lower than women diagnosed with PE or at high risk for PE, 6.61%, and women with early FGR or at higher risk for FGR, 6.80%. Yet, even as we speak at this moment in India, the focus of almost all fetal radiology ultrasound sessions or conferences or meetings or whatever names you call them remain almost entirely on congenital abnormalities. And that's something that we need to seriously look at. Why is that so? Yes, congenital abnormalities, chromosomal abnormalities, the detection of which are important. There's no second guessing on that. There's no saying that they're not important. But why would you not look at something that is more prevalent, something that is there in large numbers, something that has equally serious consequences, both on the health of the mother and on the health of the fetus, short-term consequences, long-term consequences, and long-term consequences, not just for the fetus, future generations, which in turn implies long-term consequences for the overall health of the country, which is a matter of concern when we consider the high magnitude of metabolic syndromes in India. So why would we not focus on that? Is something that is, to put it mildly, quite surprising. Challenges and opportunities that we have. Every challenge is an opportunity. Every opportunity is a challenge. Integration of fetal Doppler. How do we scale that up even further? The prescriptive practice of low-dose aspirin, where the radiologist recommends the administration of low-dose aspirin to the obstetrician, who then says, well, I don't like 150 milligrams, I will do 75, or I will go by weight. And it's good that FIGO has now come up with 150. Earlier, we had papers from India, a few papers from North India that had shown how 150 is much better than the use of 75, but still there was resistance, and there still is resistance to the use of 150 milligrams. But we are seeing that evidence, and Samrakshan is showing some evidence on these aspects. Longitudinal follow-up assessments, how do we improve that? We are with a population that either does not return for follow-up for whatever reasons, whatever constraints and limitations they have, or goes window shopping and moves beyond. We have referring doctors who decide that, well, I'll keep everyone happy, so I'll send you once to this doctor, I'll send you once to that doctor. So how do we improve the longitudinal follow-up assessments? How do we improve compliance with antenatal care schedules? How do we improve a multidisciplinary team approach, which is what we started with Samrakshan, where we had outreach programs, outreach initiatives, discussions with the obstetricians, with the gynecologists, with the neonatologists, with geneticians, with concerned stakeholders, policymakers, district level health workers, health managers, health workers, ASHA workers, the whole set. And how do we build in a multidisciplinary team approach? Because it's not just about one discipline or another discipline doing it. It's about doing it together and doing it correct, doing it well together. We also looked at questions in terms of, we are also looking at questions in terms of, our estimates of FGR based only on the estimated fetal weight and biometry value. And we are saying that what are the implications of abnormal Dopplers in the EFW more than 10 centile? So then should we look at functional effects more than the biometry growth parameters? Do we look at both together? How do we balance that? Do we give equal weight for it? So when we consider the diagnosis of FGR, when we consider the management of FGR, how do we place the balance and how do we weight these factors? And that's something that we need more data from India, especially as we have inconsistency in the use of charts, growth charts. And we have, as rightly pointed out earlier, we have either an undercall or overcall if we use the charts based on Indian data. And again, if we rely on Hadlock was not developed with any consideration for Asian Indian population. It's a smaller number long back. So does all of this work? So do we need our own data? And leads us to, we need normative fetal Doppler parameters for our population. And we have put this out, or we have submitted this paper where we have shown that the mean uterine artery values at the 95 percentile level are different for the population that we saw in Samrakshan compared to the global reference rate. It was not different for the, not statistically significantly different for the 5th and 50th percentile, but at the 95th percentile, there was a significant difference. So then we need to have normative fetal Doppler parameters for our population. We need normative fetal biometry parameters for our population. And we need to incorporate that into the machines that we use for our population in our country. Moving forward, we are going to look at preterm births. We are going to look at predictive algorithms for a variety of conditions, including preterm births. We're going to look at stillbirths. We're going to look at the fetal environment. We are going to look at perinatal hypoxia. We are going to look at the placenta. And we are going to look at maximizing and obtaining more of our data and generating more evidence from our own data based on our own pragmatic real-life experience from the ground. We are also adding on multi-center studies to the program, targeting focus questions, and that has started, and we have started a few multi-center studies now with very specific focus questions, and where we get into greater depth. So building in on top of the program, we are now starting to build in a more structured, more systematic, more rigorous, if you might call, more rule-based research program. And it all comes from the fact that we know and we understand that there are a lot of questions to answer that we need to answer to improve our capabilities to provide the best possible care for. We are looking at automated data capture and mining so that the hassle of re-entering data onto a paper or onto an Excel spreadsheet or onto a Google form is taken care of, and that we capture data directly from the machine. And equally important, we are starting to work on the development of dedicated skill enhancement training centers, where we can train people on the ground, in the communities, within institutes, within diagnostic centers, within individual practices, how to implement these processes, not just as a theoretical exercise, but as a practical, do it yourself practical exercise. We have decentralized, we try to decentralize as much as possible. We believe in that. And we have now 2 decentralized community models of Samrakshan that are coming and that have started actually. In Guna, Dr. Lalit Sharma has started the IRIA Barossa program that is integrating with the district health managers at different levels, including the district collector and the district health workers at different levels, the IRIA Barossa program. At Hardha, again in Madhya Pradesh, we have Dr. Akanksha Begal, who has started the integrated Samrakshan clinics, where she is building in and has already started building in a multidisciplinary team that works together, including a data entry person, including the obstetrician, including the radiologist, the fetal radiologist, the neonatologist, all working social workers, all working Anganwadi workers, ASHA workers, all working together to provide a complete package of care for the women. So we have the decentralized community models of Samrakshan that have started coming. Now I'd like to dedicate this talk to the selfless practitioners who shared funds so that we could improve collectively. Without them, there is no Samrakshan. Samrakshan, Dr. Shilpa said Praveen is the backbone of Samrakshan. Completely wrong. I'm an appendage somewhere in the whole body of Samrakshan, possibly the appendix. Samrakshan, the backbone is the practitioners who have done the protocols, who have implemented the protocols, who have filled the forms, who have come back to us and told us that, well, this is not working, this is working, and who have helped us to improve collectively. This talk is dedicated to each one of them. Equally important, this talk is dedicated to all the women who help us find answers. all the pregnant women who help us, who allow us to assess them. Not a statistic, they're not a statistic, they're more than a statistic, they're more than a scan image. Without them, we're not going to gain knowledge. And I leave you with a message from Dr. Kavita Aneja, who is from Delhi, who's also a member of the Samrakshan committee. I feel for the cause, do you? The doors of Samrakshan are wide open for any practitioner at any level, any fetal radiology practitioner at any level of care to become a participant. You can walk through at any time. You can join us at any time. You can be part of the program at any time. So once again, thank you for giving me the opportunity to share the results with you, and let me stop talking and let me stop sharing.
Absolutely. Thank you very, very much, Praveen sir. As I said, you are saying that we are backbone. Okay, we are filling the form, but tabulating them and letting us know what are the things are happening, that an appendix cannot do. So you can't say that. You are such a major part of our team, basically. So thank you very much for your wonderful talk and the description of whatever we have done. There is one question for Bimal sir, one question for you. In late FGR, is it uterine artery PI or the umbilical PI which is important?
Question is that in Delphi consensus, what it is the umbilical artery which they have taken into the Delphi consensus definition. But for all practical purposes, you have a fetal weight less than 10 centile, and even if you have a uterine artery which is abnormal, you should take it as FGR. Because usually, umbilical artery abnormality will come much later in late onset FGR. Especially if you are doing your scans at 34 weeks, 35 weeks, you may find umbilical artery not greater than 95th centile. And that actually, more than the 32 weeks period, I feel we should use umbilical artery abnormal at definition. Actually tells you that this is more likely to be an early onset, and if umbilical artery is normal, this is more likely to be late onset FGR.
Can I just add on to that? One thing that we need to realize with the Delphi consensus is that it's a consensus program that is usually by invitation, that is built on the experience and some amount of evidence that is there all over the world. And it's a consensus statement built on the personal experiences of experts. Now, if you look at where they come from or the levels of care that they work in, a Delphi consent, not just in radiology, I'm not just talking about this, but in any field of medicine, has its limitations in how much it can apply to all situations. So when we say it's a consensus statement, a Delphi consensus statement, that is one way of developing a consensus. It doesn't end there. That's the beginning of then saying, if I apply it, how does it work? And do I need to alter that? And you can actually check this. You would find that in any medical discipline, so it's not a pointing of fingers at this particular Delphi, you would find that consensus statements appear. They are then consensus statements appear, and they are then recommended to be applied, but no one evaluates that to see what happens. And when no one evaluates that to see what happens, there's nothing to say that, well, they are actually doing the good that they're supposed to be doing. So you go back to that, and then you can cross-check this. You go back to that and say, well, where are these statements coming from, and where are they picking that from? And for most parts, you would see that they come from certain systematic reviews, they come from certain meta-analysis, but the amount of data that goes into that, the amount of evidence that goes into the making of that is small. So Delphi consensus statements or any consensus statements provided by any society gives you the initial framework. It's my personal opinion, gives you the initial framework to start building on. It does not say that's the end. You have to build, you have to implement, you have to evaluate, you have to go and revisit those statements to see if they are actually doing the good that they're supposed to be doing.
See, honestly, the problem is that most of these consensus and the meta-analysis or the guidelines that we get, see, we just read the conclusion of that. See, if you read every word through that, if you read the fine print, you will find that there are so many things. Even if you go look at the Delphi consensus, you will find that it wasn't 100% consensus. They've already made statements that there is so much that still needs to be, we are not able to define. And then meta-analysis generally is written by people who actually do not work on the field. See, they sit and just make meta-analysis. They just collect data and they just put it across. So as you rightly pointed out, we need to use it as a starting point. And we need to see also that whether we can validate that in our own practice. The same is the case. I think the biggest question at this moment in the world for FGR is which growth chart to follow.
Exactly.
Now we've got so many growth charts, and every time something new walks in, we feel, oh, this is the final thing that we've got. We got the intergrowth, and everybody felt, wow, wonderful. This is real standardized, done at so many places in the world. But there were immediate contradictions, and yes, it doesn't work. We were very happy. For years, I've been using the Mediscan data, and I was strongly felt that yes, we need to have our own local. But then again, that is a population reference chart. It is not a population standard chart.
Exactly.
So they have taken every pregnant woman into consideration with anomalies, without anomalies, all FGRs, everything.
Yes.
So definitely their 10th centile actually undercalls.
Exactly.
And that is why last 3-4 years, I have been a very, very strong propagator of doing Doppler for every growth scan. Let us take use of hemodynamics because, there is a study by the Nicolaides group which says that no, that has actually led to more intervention, everything. But you look into our own practice. See, all scans are done by different people. Early pregnancy by someone, anomaly by someone, then you have the growth scan by someone. Now, how do I get the velocity?
Exactly.
It's just nice for a definition going down by 2 quartiles. But have I done the previous one? How much of standardization we have on biometry? Then India is such a huge country. Like, I was speaking to Prashant Acharya. He said, see, Suresh chart is a Dravidian chart. My chart is an Aryan chart.
Yeah.
And even ethnicity, everybody, South Indian is getting married to a North Indian. So this complication is not going to go off early. We need to make the best of it. We just cannot say, okay, this is too complicated. Let us not go forward. Yes, with whatever evidence we have. So I think we need to use Doppler. We need, at least in our country, we need to promote the use of Doppler for every growth scan. And you don't need to just deliver because there is a Doppler abnormality. It just tells you, yes, this is the fetus that we need to put them into more closer surveillance than.
Yes, that has been the challenge with Samrakshan also. We have said that we want to do fetal Dopplers for all fetuses. And then the challenge was that, well, if the EFW is more than 10 centile, why? And so when we did it, we found that if 10% of fetuses with an estimated fetal weight more than 10 percentile are having an abnormality, then are we missing something? Again, as you said, not all of them are going to have a problem. Not all of them need to be delivered immediately or even in the near, but at least you're starting to think that, well, I need to look at that and I need to look at them and I need to see what is happening with them. And maybe there's a group of them that can be helped and that needs immediate intervention or closer to near immediate intervention.
I can show you multiple cases I have had which at 34-35 weeks were AGA, but with CPR less than 5th centile. We put them on closer surveillance, and 37 weeks, 38 weeks, yes, the Doppler changes increased. They became SGA, and there are times where people have neglected our recommendations and said, abhi to umbilical artery is normal, let us do, and they have gone into IUDs also. I have 2 cases on that, which just because they did not understand the concept of late onset FGR. They just thought the cascade is still going to take place. We're going to get a DV abnormality. So that is why this goes wrong. And so I think Doppler for all, at least in our scenario where multiple people are doing different scans, should be the essence of the message that I would like to give. I get a lot of contraindications at so many places where I speak on this, but I still stick to my own feeling about it.
So that is the second motto of our Samrakshan, to integrate Doppler studies in all the growth scans. The second motto is the same. So, Sir Praveen, sir, there's one question for you. Sir, where is the data available for Indian population?
Let me add on. Shilpa, can I add on to
yes,
what
sir,
has been discussed?
Yes,
Yeah.
yes.
See, I do agree that in the last whatever that Praveen and Vimal sir has right now said about this Delphi consensus, I had a presentation on early FGR, Bain or Boone. I just split in the Delphi consensus on FGR. If you look at this, 56 experts were submitted, 55 came from tertiary centers, and 38. Am I audible?
Yes. Yes, you are.
Yeah. 38 experts were from now US and Europe. Only 10 from Asia, 5 from Africa, and 5 from Latin America. So you can see the skewed this thing of a population like India is contributing to nearly 20% of pregnancy and childbirth, and then absolutely very minimal data is coming from India. So as Dr. Praveen rightly said, this is consensus is the beginning point, but we have to apply it in. And Samrakshan is such an attempt that we did, but it has to be on a much larger scale that we have to do it. And all stakeholders has to be brought in along with this IRIA Samrakshan project. So let me, at this point of time, I'm surprised to see Dr. Evelyn Ho-Laming still with us, because Dr. Evelyn had some other commitments. I think something has charmed Dr. Evelyn to stay back. Dr. Evelyn, please.
Oh, no, I thought it was very interesting.
Can you unmute?
Yeah, I thought it was interesting, and I wanted to listen to exactly the scenario in India. And you rightly pointed out that a lot of the consensus statements, which I take issue with, is done by people in high resource countries in the West. And Asia is like one small group, little bit, and it's like almost token. You have a bit of Africa, a little bit here and there. So, and then they impose that on us and expect us to do, the so-called bidding. But you're all absolutely right. That is a starting point for us. I think one of the main reasons Asia may not have that kind of clout is because we don't have the resources to keep collecting that data and then come up with this huge database. And I think IRIA Samrakshan, you're going in the right direction. And the reason why international, people are taking notice is because it's a big group. So if you keep accruing this data that you have, you may even say, hey, in Asia, we should do it this way. These are our reference points. And this is where we go forward. So I think it's a very, very good step. And I really would love to see you all carry it on and keep collecting the data. For example, what Dr. Bimal felt, what he feels that Doppler should be used. And then actually prior to this, I had to Google on eclampsia. It's a long time since I did my ONG. And I found out that there are centers who are promoting screening of Doppler even in Western countries. So I was, probably not indicated in terms of consensus statements, may or may not be required for them, but may be required for on this side of the world, this side of the world, or even in Africa or sub-Saharan Africa, as you mentioned, or even Latin America, where you have a lot of low resource countries. So very interesting information. I mean, Dr. Praveen also gave a lot of interesting information on how great that, that little extra effort, which by the way is a lot of effort, because if you add every additional patient, that 2 minutes that you take, it becomes a lot in a day. So yeah, it's very interesting data. I hope you'll successfully continue to accrue data and then provide the evidence, because India is a huge country. By yourself, you can be a huge database.
That's what I always say. In 2018, the whole of European continent had 48 lakh live births. In one state of India, in Uttar Pradesh, we had 52 lakh live births. So the kind of data that India can provide to the world is huge, but we are not tapping it. That's a problem.
Yeah, the thing is to put in resources. Government has to put in resources. It's not just institutions. You need the government supporting you. And, you know, everybody is fighting for that pie from the government. So, you know, food obviously is very important. And I would say maybe your fetal deaths also contributed a lot by malnutrition and undernutrition. It happens in all our countries which have got, you know, rural areas. That's one of the things. That all contributory in the whole big picture, you know. But I think India is fantastic. If it shows that this is the way to go, then I think many countries will have to start following this technique. That's why I felt that this was a rather interesting project, and it's amazing that you have got this far, and encourage you to keep going. I don't know how you're going to get the resources.
Evelyn, there is one major, Evelyn, one major problem that you come across when you interact with the health administration or the government is they are all focusing, and even the non-government agents are all focusing on the primary intervention, on improving nutrition and all those two. Very good. But this kind of an approach where we can target and risk stratify and apply focused management, prevention or interventions can give better results in a short term and can make a real big difference. That's what we are trying to say. But then the argument from there is that whenever we say technology, they say it's costly. But instead, they are all spending crores and crores of money, millions of money for primary intervention, which has all these 75 years of has not given sufficient momentum for the whole thing. The maternal mortality in India is still somewhere around 113. That is all huge numbers that we have still. So this is where a mental block from the governments also has to be overcome, that they always feel that anything that comes with technology is costly. Anything, whether it's a biochemical test or an imaging biomarker that we are trying to, they say that think that this is all costly, India cannot afford it. So maybe in many of the countries in Asia Oceania, maybe also the government officials will have this kind of a attitude. So how to overcome that? What are your suggestions?
So I do exactly what you're doing. Your Indians IRIA Samrakshan paper, which published your data and which I think Praveen was partly sharing as well. It's very impressive. So it's a matter of time before you accrue even more data, say in another 2 more years of keeping at it to show a significant difference. I think if you look at what WHO, is it United Nations, they're trying to eradicate cervical cancer. So how is their prevention? They're doing this self-swabbing, you know, HPV testing and vaccination. Now, vaccination is very expensive, even in Malaysia to give that vaccination. But that HPV test is very helpful. So if WHO is looking at prevention as a cheaper alternative to treatment, then that is something that we have to keep lobbying our governments for. And I know in you know, it's like every state in India is like bigger than some countries. You know, your states are huge in terms of not just number of people, but in terms of its size as well. So I can imagine the logistic problem, but actually, this is where ultrasound, if we keep using it, the costs will come down. And like we did, I remember some pilot project where they used the mobile phone to do the, you know, ultrasound for antenatal checkup, and it does save women's lives. And that they can just go in, the midwife just goes into the village to do it. So I think these are the types of areas in which we touch on using technology to prevent disease, then the governments will be better. And I have to agree with you, all governments like what looks good to the people. So, so it's the same with breast, right? It takes a long time to tell them prevention is better than cure. So because mammography is very expensive. So until now, Malaysia cannot afford a full-scale population-based screening program because it's too expensive. So what do? We just help women by subsidizing, or we actually encourage them if they can afford it to go for their screening. Cannot wait for government to give you something free. I think this is what this whole pandemic has also taught us. You don't wait for government, you help each other. You get there, you go forward, you do it. So I think IRIA is really leading the way. Maybe you can be an example for many of our smaller countries. And it's something good to actually present on a wider scale. That means in any international conference to present your findings and how you go about it. I'm sure a lot of low resource countries will be very interested to hear.
I think you should, there is International Society of Radiology has come out with a Safe Motherhood campaign. So there was a conference recently. So we should take these measures also, these kind of projects also highlighted the, and maybe as you rightly said about an alliance between the Asian countries, Latin American and the African countries, because these are the countries that has got the major problems on this front. So that those things I hope and wish that during your presidency, you will take lead and make a significant difference to this region. Thank you, Dr. Evelyn, for joining us and giving this valuable comments.
I just want to let you know, Hemant Patel, one of your IRIA past presidents, is a ISR council member. Lobby him to lobby them, because one voice alone not good enough. Two voices louder.
Right. Sure. We'll take it forward to Hemant also. So I'm getting 2 votes for that. Thank you. So Shilpa, any more questions or we are already past
there is one question. For Praveen sir, where is the data available for the Indian population?
Well, the IRIA has a journal that's known as the IJRI, and we have published the baseline Samrakshan paper at the start. What was the process that we envisaged and visualized? We have put that paper in there, and that's published in 2020, I think, in the IJRI. And then we have the 2-year data that's coming out now. It's accepted. You will see it in the E1st section of the IJRI now. And possibly it will come out in print maybe in the next couple of weeks. We have submitted I think 6 more papers to IJRI, and they're in different stages of review. And once they are accepted or commented upon, whichever way, then we would be putting that out it would come up in the IJRI. So the IJRI is one part where we have data from Samrakshan in. We also have put in the interim data as a series of publications and health education articles in the Journal of Fetal Radiology, which is available online, and where we have put in all the interim results that we have found in terms of fetal Doppler, in terms of first trimester screening, in terms of what it's doing, in terms of the protocols that we are using, and the whole thing is there. So we are putting out the data in multiple forms, a purely scientific academic forum like the Indian Journal of Radiology and Imaging. Also, to ensure that it doesn't just sit there in the dust-laden cobweb-filled pages of a journal, but actually translates to action, we are putting it out as videos in different regional languages, articles in different regional languages, posters, infographics, and circulating that widely through social media. So the data is there. And if you're in India, you would know that for the past 2 years, every nook and corner you can hear and see these people talk about Samrakshan and talk about the processes that are involved in it, and talk about the data that is coming through it. So the data is out there. But if you want from a purely academic learning perspective, I would suggest look at the IJRI. The first 2 or 3 papers are there. It's a paper on dating mismatch using different dating techniques, a paper on the baseline of of Samrakshan, and the 2-year results, and the remaining papers, including the mean uterine artery reference ranges that I told now, the preterm births, fetal Dopplers, 3rd trimester, the association with stillbirths. Then we have the whole issue of the reclassification of FGR and SDA also coming up as a paper, which we have submitted. We have and we are now working on the impact on PE and additional papers as they keep coming. So we'll have a series of papers that come subject to review and subject to acceptance. Or at least we'll be submitting that. And if it doesn't get accepted, then we'll be putting it out somewhere else. I shouldn't say that.
Okay, thank you. Thank you very much, sir.
Our priority was to publish it in Indian Journal of Radiology. It's a PubMed index journal.
And it's open access.
This is an IRIA project, and IRA, the ownership of this belongs to IRA.
And it's open access, so everyone can read. Put it in let's say the AJR or something, or and then you have it locked in behind a paywall, and many people can't read, can't access, can't apply. It's useful, but it doesn't actually help too many people to put it out into practice. An open access journal, local evidence, local population, local investigators. Sounds good.
Absolutely. Absolutely.
You better say thank you to everyone and stop, otherwise I'll just keep talking.
Now I invite Lalit sir to give the vote of thanks, and thank you, Elvin, Dr. Elvin ma'am, for your wonderful message. Help each other. So that was the really, really great. So we are just helping each other to help our country to solve its own problem and getting rid of the problems. We are trying the same. Thank you so much. So Lalit sir, over to you for the vote of thanks.
Good afternoon, each and everyone. I think I am audible.
Yes, sir.
Okay. On behalf of Samrakshan IRA committee, I am extremely thankful to Madam Evelyn Ho for giving her such a full-time listening to us and giving her enthusiastic word on this Pre-eclampsia Day, Women's Day. And I am really, really very happy that you shown the interest on the Samrakshan, and you have told that you will spread the message to the Malaysia also, and in other capacity as president of AOSR. Thank you very much, madam. I am very much thankful to respected Dr. Vimal Sani sir, who has enlightened us on the pre-eclampsia and early FGR. He is a great teacher, and I expect from him that he should start advocating the Samrakshan in the Sono Summit. The ultrasound body still they are not giving time for this the great cause. As you are the member of SMF and as you are a great teacher, I request you to take forward the Samrakshan in your capacity. And how I am not able to thank Praveen sir. He is our mentor, guide. Though he is younger than me, but he is far, far older than me, my guru. Thank you very much. And Dr. Rejo and Praveen, they are the two bodies, but the one soul. I thank you both.